can finish on time. First of all, thanks everyone for being here. I know last time I made a mistake and everybody got kicked out in the middle of the session. Well, towards the end of the session. But thank you for coming. It's been a wonderful series so far. We've had papers by Alex and Ray on contrasting clinician policy historian perspectives. Then we had Jim and Hannah talking about early modern and contemporary Scotland. Today we plan for about an hour, have a paper, a Q&A session. The Q&A so far has been quite vibrant, so I don't think there's a need to sort ourselves into discussion groups. Let me first introduce our speaker. We have Kirsten Horsburgh from the Scottish Drugs Forum. She's the strategy coordinator for drug death prevention. She also coordinates the Scottish National NALOXONE program. She's trained as a mental health nurse and she has a background in community drug treatment. She's also done international work. She has advised WHO's Community Management of Opioid Overdose Working Group, as well as served as a consultant on WHO UN Office on Drugs and Crime, or UNODC, Stop Overdose Safely SOS project. So Kirsten, whenever you're ready, we'll turn off our videos and mute our mics. So please go ahead.
Thank you very much. I'm going to share my screen in a moment so that you can see the presentation, but just firstly to say thanks very much for having me. I know I was asked to specifically talk about the naloxone programme and drug consumption rooms. However, I have extended that slightly because you can't really talk about those without really talking about drugs policy in Scotland and the impact that has on everything at the moment. And there have been a lot of new developments on drug policy, so it'll be interesting to have a chat with you after the presentation about some of the things I mention as we go through. So I shall just share this now. Okay, so I'll just rely on somebody telling me if they can't see it, but I'll just assume that you can. So yeah, I work for Scottish Drugs Forum, which is a charity organisation. It's a drugs policy organisation and a national source of expertise on drug-related issues for Scotland. My background, like Raiko says, is mental health nursing, and I've been with Scottish Drugs Forum for 9 years now. Initially just coordinating the National Naloxone programme and now sort of managing everything in relation to drug death prevention, which includes Staying Alive in Scotland work, which is a toolkit to support alcohol and drug partnerships across Scotland to develop their drug death prevention action plans. So I just wanted to start by obviously recognising the huge scale of loss that we have in Scotland from preventable overdose deaths. I mean, really, when you think about it, is it any wonder that we do have such high rates when we have people who are criminalised, marginalised, stigmatised and often dehumanised? Overdose is a leading cause of death. It's been described in Scotland as a public health emergency for several years now, and I think some of the frustrations have been, how long do we allow an emergency to go on for without actually making action and making steps towards reversing this emergency? And it's difficult not to draw comparisons on the COVID pandemic. When we see that when an emergency is treated like a true emergency, we see immediate changes to practice, we see resources found, we see fast-tracked law changes to address the issue, and we've seen none of that with the Scottish drug deaths crisis. So in the last year that we have data for, which was 2019, 1,264 people lost their lives that year. And it is important to remember that these are overdose deaths only. They're not deaths from bacterial infections, bloodborne viruses, road traffic accidents, violence, or anything else to do with drug use. They are overdose deaths only, so on the whole are accidental and therefore preventable. I remember when I was back nursing, and when I first qualified as a nurse in 2009, we were talking about 545 people who died that year, and it being an absolute travesty. And what are we going to do about this? And jump forward several years, and we have more than double that. So since recording started in 1996, 12,768 people have lost their lives, and we don't yet have the data for the deaths that happened last year in 2020, but we don't expect them to be any lower, which is just horrific when you think about around 3 people every day dying. Can you imagine 3 people dying every day of other causes, and what the response would that would be? It would be in the media every day. It would be reported on about the lives of those people and the circumstances that they were under, and we don't see a lot of that, if any. So that's without mentioning near fatal overdoses as well. So it's estimated that in Europe, for every fatality, there are around 20 to 25 near fatal overdoses. So if we apply that to Scotland, essentially we're having around 30,000 overdoses per year. And often they can have devastating consequences, even if the person doesn't die. So we see people with brain damage, with significant burns and all sorts of issues that they've had surrounding the circumstances of their overdose. So it's another major issue that we don't pay enough attention to. And of course, all of this, the main driver for our drug-related deaths crisis is poverty, deprivation, trauma, and failed drug policy. So you don't have to look far to find stigma in society when it comes to people who use drugs. So many opinions about drug use being a choice or some type of moral failing. And we forget that everyone has a story, and sometimes those stories are stories of unimaginable trauma. The language that we use to describe people who use drugs, to talk of them, and whilst, language may just be seen as a really minor aspect, language absolutely affects how people see themselves and the care that people receive as well. Stigma kills because it silences people and it stops people accessing the help that they need. And I think one of the things that I always think about, a really key thing when I think about stigma and how it affects people accessing help, is some of the wounds that people experience when they're injecting drugs are utterly horrific, and wounds that I have seen before on people when I've worked in the drug treatment service, and must be so unimaginably painful. And often we don't see people until they're at the point of absolute crisis with their wounds. So why is it that people would rather endure such significant pain than approach our health services? And that should be a message to all of us, that we absolutely need to improve our services to make them way more welcoming for people who use drugs. And often when they do come to our services, we question people to such a degree of personal information that just increases that feeling and sense of embarrassment and shame. What drugs are you using? Have you been in prison? Do you have any contact with children? What's your employment status? Do you have a house? And because a lot of your sessions have been around HIV as well, we ask people about whether they share injecting equipment, which is actually really embarrassing for a lot of people to talk about and to admit to. And certainly when we've seen the HIV crisis in Glasgow, which we'll talk about later, a main driver for that was the sharing of injecting equipment, and sometimes people just don't want to admit to that because they know that they shouldn't be doing it, but actually sometimes their circumstances are so desperate that they do it. And it's also incredible that we need to remind people that people who use drugs are actually human beings. I'll do a sort of self-promotional plug for Scottish Drugs Forum's resource. This is a really useful glossary of contested terms in substance use. So it addresses things like why we shouldn't talk about substance misuse, drug abuse, and all those sort of terminologies that are common practice even within our services, let alone within communities and the media. So an important document to have a look at if you're interested in the area of the language around substance use, and really goes into detail about the whys of why we wouldn't use certain terms. The other issue I just wanted to mention was around harm reduction. Over the years, harm reduction seems to have been pushed to the side a little, or in certain quarters there seems to be this impression that All we need to do is get people abstinent to deal with the drug death crisis, but we cannot afford to push abstinence onto people when they are not able, ready or willing to go down that route. It's complex. People who use drugs are complex, and we just can't afford to allow that to be the only rhetoric. We need everything. We need absolute choices for people. So if people are at a phase in their life where they want to go to residential rehab, they want some support to come off of all substances, including opioid substitution therapy, they should absolutely be supported to do that, but people should never feel pressurised into that position. And we know that drug treatment is an effective overdose prevention strategy. We should really, I always think about the Chicago Recovery Alliance ethos, which is around any positive change. So I think if we start to reframe what we support people towards their own goals, and for some people that might be getting contact back with their family, or it might be the first time they start using sterile injecting equipment every time and they stop sharing, or for some people it could be complete abstinence. So there's an absolute spectrum, and any positive change is the ethos of the Chicago Recovery Alliance, and one that I particularly like. Harm reduction is a public health philosophy. It's UK used to lead in harm reduction, and we've now fallen quite behind several other countries, and we'll come to talk about what we don't have that we should have. When you think about harm reduction, and apologies if this is things that you're absolutely aware of, but harm reduction provision would be things like sterile injecting equipment, safer injecting advice, naloxone, and a whole range of other interventions in that way. And harm reduction shouldn't be seen as a radical concept, particularly when there's overwhelming scientific evidence that it works. Harm reduction is not about stopping people using, and it's not about encouraging people to use drugs. It's just about accepting where people are at, and treating people with dignity and respect. But it's really difficult to embrace harm reduction to its full potential while we still criminalise people who use drugs. We wonder why we have a drug problem in prisons when we continually send people who use drugs to prison. So harm reduction is something that we absolutely need to fully embrace, properly resource, and if we don't provide harm reduction, it's like throwing people into the middle of the ocean without a life jacket. So drug consumption rooms are an area that I have a specific interest in. In 2015, I undertook a travel fellowship, and I went to Australia and spent a couple of weeks within Sydney's medically supervised injecting centre, and researched the topic from there on, and have visited drug consumption rooms in several other countries. This view actually is the view from my old office desk back in the day when we used to do things like work from an office. And I could literally look out of my office window in Glasgow city centre down onto this lane and view people injecting in this lane. The lane's a sort of dead end, so it's not a through road. So it was quite an ideal spot for people who wanted to have a bit of privacy. So they would collect their injecting equipment from a nearby pharmacy, and then come into this lane and inject. And myself and colleagues were down in the lane several times to check that people were alive when we saw them. And I think it's just such a sad and shocking state of affairs that this exists. It's a real source of frustration actually visibly seeing this and knowing that there is a solution, and knowing that we could provide people with a safer alternative, and we're just not doing it. And utterly inhumane to allow people to continue in this manner. So this is pictures also in Glasgow City of a couple of sort of derelict areas. Just before my travel fellowship, I went out to view some of the sites that people were injecting in. It's estimated that around 500 people injecting in Glasgow city centre and using sites like this, or abandoned buildings, car parks, public toilets, a whole range of different areas to go and inject. So we provide people with sterile injecting equipment fully in the knowledge that they're about to go and inject in a completely unsafe and undignified, inhumane environment. So Glasgow City actually did a public health needs assessment around people who injected in the city centre, and there were a range of recommendations that came from that report that was published in 2016. Two of the main recommendations were for new services, and one was heroin assisted treatment and one was for a drug consumption room. At the minute, we have the heroin assisted treatment programme in Glasgow, which has been around now for maybe a year and a half. It's difficult to tell when 2020 was a bit of a write-off, but just over a year that service has been operating. It's obviously for a very small number of people, but still that's not meeting the needs of these 500 or 600 people injecting in the city centre. This is the Sydney medically supervised injecting centre. There are around, definitely almost 200 of these facilities now across the world, mostly in Europe, but also in Australia, Canada, and other areas. Huge benefits to providing this type of service. They engage and connect with people in a way that no other service does, because most of the services that people will attend, you cannot go if you are intoxicated or if you're in possession of drugs, whereas this is the complete opposite. You can only attend this service if you're in possession of drugs, and you pick up your injectant. You bring your own drugs, you tell the staff which drugs you intend to take. You come through to the injecting booths, you're given your injecting equipment by the staff, and then you sit in one of these booths and you can use safely while staff are there to support you if anything goes wrong. So when I spent my couple of weeks in here, certainly there were a few overdoses, mostly just handled by giving person oxygen. So none of them required, I can see there's an issue with your Zoom setup again. So we've got 10 minutes left before we're going to get kicked out of this session. Sorry, Raiko, I don't know if there's anything you can do to prevent that, but...
Hold on. Please keep going. I'll try and fix that.
Okay, no problem. Sorry, lost my thread a bit about where we were there. When I was there, most of the overdoses managed just with oxygen and no need for naloxone, because what happens is obviously the staff are there immediately to respond. So if you are there to immediately respond to an overdose, it's really rare that there would be any complications with that. So in all of the drug consumption rooms all over the world that have been operating since the 80s, there's been no recorded incident of any overdose fatality within any of these services. So, but of course, one drug consumption room in Glasgow is not going to affect drug-related deaths across the whole country. So what we do have currently in Glasgow is concerned members of the public taking matters into their own hands. So you may well have seen this in the media. So we have Peter Crykant, who has started his mobile van in Glasgow City that now operates a few days a week. And he's certainly been having a huge response to that. This is essentially illegal to provide it, well, according to the UK government. But we're now stuck in this situation where the Scottish Government says that Westminster needs to approve it and make an amendment to the Misuse of Drugs Act, when actually we strongly believe that the Lord Advocate in Scotland could allow a statement of prosecution policy not to prosecute people actually delivering these services. And of course, the key bit that I didn't mention when I first started talking about consumption rooms is the reason for the public health needs assessment in Glasgow was because of the massive increase in cases of HIV within the city. People injecting drugs, injecting cocaine as well as heroin. So the number of injecting incidents had increased. And also that meant that people were sharing more equipment and hence the spread. So that's ongoing now. I think around 150 cases of positive HIV cases, and most of those people actually receiving treatment for that, but obviously extremely concerning. And the case for a consumption room in Glasgow has been described as the most compelling in Europe. So on to naloxone, and the national naloxone programme in Scotland was introduced in 2011 following the success of a couple of pilots. And I guess the sort of main parts of the programme are we we provide it to anyone who is likely to witness an overdose. So that might be family members, friends, people who use drugs themselves, staff working in drug services, and a couple of other national initiatives that I'll go on to explain. And we've supplied around 80,000 naloxone kits across the country to those individuals. And we receive note that around 1,000 of them are used per year to reverse potentially fatal overdoses. You know, that's obviously significant. There has been some discussion around Scotland continues to have this extremely high rate of overdose deaths. However, you have this national naloxone programme and you've supplied all these thousands of kits, so surely that should be making an impact. But the response to that really is, if we didn't have a national naloxone programme with so many naloxone kits out there, our drug deaths would unfortunately be even higher than they currently are. So it's absolutely crucial that naloxone is there once an overdose occurs. There are things that we can do to stop overdoses happening in the first place, but once it's happened, naloxone absolutely needs to be available. So I guess I would ask the questions to yourselves as well. Do you feel that you are a person who is likely to witness an overdose? If you are you carrying naloxone? And if you're not, please go and get one. Most of the services that provide naloxone are drug services, pharmacies. GPs can prescribe it, although don't massively. It's provided for free to anyone likely to witness an overdose, so absolutely worthwhile to get a hold of. You just never know when you might come across somebody who's overdosed and be able to potentially save their life. 86% of the deaths in Scotland involve opiates. Naloxone's a medication that obviously reverses the effects of opiates, so crucial that it is administered in a timely manner. Even when the person's been using multiple substances, it's absolutely okay to go ahead and administer it. It just unfortunately won't have an effect of it on any of those other drugs. So the main national initiatives around naloxone more recently have been around Police Scotland doing a test to change with police officers carrying naloxone, the intranasal spray. So police in Glasgow East, Falkirk and Dundee are currently undergoing training to be able to administer it, and there have now been 6 or 7 episodes where police have actually administered it, and they've only had their training started over the last 5 weeks. So I mean, it's fantastic that they have done that, but it's also a sad state of affairs to realise actually how prevalent the incidents of overdose are. We also have done some work with Scottish Prison Service so that all their prison officers on the night shift have access to naloxone when there's no nursing staff available, and we'll be doing more work with the prisons over the next year to train more prison officers. And of course, people get naloxone when it's supplied to them as a take-home product when they leave prison if they're at risk of overdose. We've done some work with the Scottish Ambulance Service, who obviously already administer naloxone around 5,000 times a year, but they are now also providing take-home naloxone kits to people who experience a near-fatal overdose or their family members or other witnesses at the scene. So a huge programme, and one that we absolutely can't afford to be complacent about, and we need to just make sure that naloxone is absolutely standard for anyone likely to witness an overdose. Just moving on, I'm aware of time, so moving on about treatment. Obviously there's the Orange Guidelines, the Orange Book as it's referred to, which is your clinical management of drug misuse and dependence. I would say drug use and dependence. Which was the sort of manual that prescribers would work by. But a sort of development from that has been medication-assisted treatment standards that have been driven through the Drug Deaths Taskforce, which I'll mention in a moment. Absolutely crucial that people have access to equitable treatment. We often describe people as hard to reach, but actually it's mostly the case that our services are just hard to engage with. It shouldn't be easier to access illicit drugs than it is to access treatment. We need our services to be low threshold. We need optimal services. We need a culture shift within treatment services so that they're much better at engaging and empathising with the client group. We need more outreach. We can't just sit back and assume people will come to our clinics. We need injectable options like heroin-assisted treatment. And what the medication-assisted treatment standards will do for Scotland is it's a significant piece of work that will provide a sort of framework around the inspection of services so that we ensure that there's equitable care provided across the country for same-day prescribing, rather than people having to wait weeks to get their prescription, choice of treatment, retention in services so that we're not just discharging when they're deemed to be non-compliant with the service's expectations. They need to be focused on harm reduction and making sure that we provide harm reduction interventions. And really a lot of the standards as well are around system changes, so things like ensuring that we have good links with mental health, primary care, trauma, etc. So huge amount of work going on in relation to that. I just wanted to mention a few documents. So there was obviously a couple of years back now the new drug and alcohol treatment strategy, Rights, Respect and Recovery, developed by Scottish Government. There are probably changes required already to that, and disappointingly there wasn't a huge amount of discussion on drug-related deaths in that strategy. However, rights is obviously about the right to life, and we just need to be much clearer about what we need from services and need from drugs policy to address that. The one in the middle there was a Dundee Commission, an independent report from the Dundee Commission around the services in that area that was really quite critical of the services in the area. And although the recommendations are there for Dundee, they're absolutely relevant for across Scotland. Then we had a really extensive inquiry into problem drug use in Scotland by the Scottish Affairs Committee. It had also a range of recommendations. Some of the sort of more, the ones that were seen as more controversial, which they shouldn't be, were about decriminalisation and drug consumption rooms. The whole range of recommendations went to the UK government and they only approved one, which was about addressing stigma. So totally short-sighted and absolutely hopeless from the UK government when it was such a really well thought out inquiry. The Staying Alive in Scotland work is the one that I mentioned at the start that we work on, and the Drug Deaths Task Force was introduced and they first met in September 2019 in response to the rise in numbers of drug deaths. I'm an observer on the task force. I'm going to just quickly show you a slide in a second about the priorities of the task force, but subsequently in 2020, when the drug deaths for 2019 were announced, unfortunately, the Public Health Minister at the time lost his job over that and was replaced with a new Drugs Policy Minister, Angela Constance, who's reporting now directly to the First Minister, and a new Drugs Policy Division has been set up by Scottish Government with the promise of extensive funding over the next 5 years. So actually, finally, the Scottish Government have admitted that they've not paid enough attention to this issue and that they're now committed to a range of strategies and mostly in line with the Drug Deaths Task Force priorities. So the key priorities from them: targeted distribution of naloxone, more on near fatal overdoses like I mentioned earlier, so that's great to see that as a priority as well. Medication assisted treatment I've mentioned, targeting people most at risk, public health surveillance and supporting those in the justice system. So a huge amount of work to do over the next 5 years, so lots of activity happening just now. But I guess the onus is on all of us. So it's all very well having money, but the onus is on all of us to do something. We can't afford to continue as we are. If nothing changes, nothing changes. So I'm sorry that I maybe went over my time slightly there, but hopefully we've still got plenty of time for questions. Thank you.
Thank you very much. That was a wonderful presentation. Shall we jump right into Q&A?
Could I start?
Please go ahead, Steve.
Yeah, Kirsten, thank you very much indeed for that. Absolutely, well, fascinating and really, quite moving to see the work that you're doing and the importance of what you're doing. I wanted to ask you, just a really very sort of broad question in the context of this program of mini workshops, which is thinking about Scotland, especially in relation to the global circulation of ideas and so on. And I was just thinking, I mean, you mentioned the importance of culture change here in Scotland around injecting drug use. And I just wondered, you were also when we were chatting before your presentation, you were talking about visiting other countries, seeing how things were done elsewhere, and the sort of exchange back and forth of ideas. And I just wondered if there was, in terms of cultures and culture change, whether there were things that you had learned elsewhere, or if you saw particular aspects of Scottish culture around drugs use that could be taken elsewhere.
Thank you. So, yeah, I mean, there's probably quite a few areas that I could talk about there, but I think one of the main things that cropped up when you were talking there was when we talk about so medication-assisted treatment, as we're now calling it, we have around 40% of people who require treatment in it within Scotland. So we have around 60,000 people experiencing drug problems, and only around 40% of people actually receiving the drug treatment that they need. And that's obviously a major fault, that we don't have enough people in treatment. And one of the major culture issues for me around that is that we're so quick to discharge people when they're deemed to be not complying with the service's expectations. So they're maybe not attending their appointments, or they're continuing to use on top of their prescription. And we're so quick to discharge people. So when I've spoken in other countries about that, people are horrified that that's the case. And then they'll say things like, well, no wonder you have such high rates of drug deaths if you're continually throwing people out of treatment. So for me, that's a key thing that we need to absolutely change. And I have seen change over the last couple of years, certainly, in respect to that. But I mean, way back when I was working in drug services, and this still happens in some areas, that, if, for instance, you continue to use and the service is worried, rather than increasing your prescription, doing everything that they can to keep a hold of you, you'll be discharged and quite often be told not to come back for 3 months and go away and work on your motivation. And I just find that utterly unbelievable that we would say that to people. How on earth can you expect people to be motivated to come back to treatment when you're going to throw them back into a life of chaos? So all of this in and out of treatment, that needs to stop, and we need to make sure that we are keeping people in treatment for as long as they need, want, whatever, and actually giving people proper choice. In relation to naloxone, that's where we're leading the way in Scotland. So when you speak to other countries around their naloxone provision, they're absolutely jealous of what Scotland has. So some countries really struggle with some of the regulations that they have around naloxone provision, or funding to support naloxone being available, or just general resource, or general, again, culture that, with a very much an abstinence focused model, and naloxone maybe doesn't fit with their perceived abstinence model. Is that then diluting the message of abstinence if we were to provide people with naloxone? So it's so complex, but I think for me the treatment issue is probably the major one. But of course, when you speak about some countries, I mean, we're lucky in comparison to countries like Russia, where methadone's illegal. So yeah, it's variable. It depends on your perspective, I guess.
That's really interesting. Yeah, very helpful. Thank you. I think it raises questions about the priorities that beset our health services more generally as well, and yeah, things to think about there. Thanks.
Yeah, thanks. And I guess just completely behind as well, a lot of areas, especially in the areas of providing drug consumption rooms, or what Portugal's done by decriminalising. And, these are sort of things that we should be on the front foot of. We should be leading in these areas, and we're just not. And quite often we're ignoring the evidence from other countries as well. You'll see it a lot just now with the run up to the election as well. All the politicians putting forward their views about how they plan to address drugs policy. And I just watched the interview with Douglas Ross last night with Peter Smith on ITV, interviewing him about his desire to get everybody into rehab, but completely ignoring the evidence around drug consumption rooms, admitting that there is evidence and the evidence is strong, but just doesn't feel like it's something that they should do. It's just infuriating to just, such compelling evidence for an internationally recognised health service, but nah. So, yeah.
Welcome.
Hi, Kirsten, great, I have to say, great talk, really good. I really enjoyed it. I'm sorry you missed some of my talk, which, which touched on some of the same problems, which is basically the essence I was putting forward was that, yeah, the change happens, but it only happens when societies are threatened by it. And the problem is they're not particularly threatened by drug deaths. So they're threatened in politically, etc., but they're not. But the real, you touched on the real crux of it, which is that the Attorney General has within his remit he could add a sentence establish drug consumption rooms, and all they're doing is kicking the football back and forward between each other. Scotland is trying to persuade us all that it's down to the UK's intransigence. And I said the HIV experience with needle exchanges demonstrates because they established needle exchanges without any law change. They did not require anything to happen. And I think that's the thing that we presumably have to step on or pin the politicians to the table about that, because they're the ones that are not making. And it is because there's generally people don't like drugs and drug users, and they have their opinions, and they do not want to. And I think that unfortunately, one of the comments I made was that unfortunately, that resistance is all the way through the service. I mean, as in from politicians right down to members of staff, it's there. And that's a problem, that we have this big difficulty, culture change, persuading people that it's not a dreadful thing, that we have to, it's an illness that has to be treated.
Thanks, Ray. Yeah, absolutely. And yeah, I'm sorry that I did miss
okay.
that. Go back to it, definitely. But yeah, and of course, people who use drugs don't vote either, generally. So that's, another point. I think there's a lot more pressure on the issue now, and I think over the last few years the media have really taken the issue under their wing as well, in a much more positive way than they ever have done before, and kept the pressure on. But in relation to the drug consumption room issue, we've now got this nonsensical situation where we've got this man delivering this service in Glasgow. He's not being targeted by the police or being prosecuted for it. So are we just going to have this forever now? Is this going to be the case, that we just have this sort of dubious regulatory issue around drug consumption rooms, and we're not able to? And it's really frustrating for the colleagues in Glasgow who've put together a really solid business case on providing a much broader service within the drug consumption room, because it's not just about consuming drugs, it's about linking people into other services that would support positive changes in their life. So supporting people into treatment, supporting people into support with their welfare, their benefits, all that side of things, their housing situation. And one van in the city centre of Glasgow isn't going to do that. But what Peter's done by providing that has kept it on the agenda, has kept the pressure on, and kept the profile of it. But you're absolutely right that we need Scotland to step up and say, well, okay, if Westminster's not prepared to support it because they're working from an extremely outdated Misuse of Drugs Act that was produced in the 70s, that wouldn't even know what a drug consumption room was at that time, then we need to just get on and do it. And maybe if there's a change in Lord Advocate with the next Parliament, then maybe that's a possibility.
Thank you, Kirsten. Really enjoyed your talk, and thank you also for this really important work that you do. I had two questions for you. The first is it's similar to what Steve was asking, and it's sort of wanting to hear a little bit more about your experience on sitting in sort of within the WHO and sort of these international kind of discussion around, you know, how we go about dealing with this, the crisis. And I was wondering whether you saw there also whether there's an appetite for culture change there as well in how we talk about these issues. So moving away sort of only sort of in the public consciousness as thinking about the war on drugs and things like that, and stigmatization of drug users and drug use, whether there is that sort of push towards a change of how on how we talk about these at a higher level. And the second was, this is not my field, so it might, I don't know whether this is a sort of an appropriate kind of comparison. The only other context I know a little about is the Swiss context, where, you know, they have the heroin assisted treatment, and I was wondering how what we have in Scotland compares with that, and what your thoughts were on sort of evaluating these kinds of approaches.
Thank you. A few items in there. So yeah, in relation to the World Health Organization issue, and you know, they obviously have clear guidance, and really usefully actually recently with the COVID outbreak as well, there was clear guidance about what constituted essential care for people who use drugs during COVID, because I think what happened was a lot of services just closed their doors basically, and you know, the WHO put out clear guidance about, no, these things are essential, so provision of sterile injecting equipment, drug treatment, etc. So that was really useful to see. So I think they've always had a good positive role in that. What's probably been most interesting to me in my work has been the work from Harm Reduction International, who are an organisation that, you know, there's folks are nodding, so you're obviously aware of it. But I usually am lucky enough to attend their international conferences, and I think those are always really interesting events, because you are hearing from people from literally all over the world. So particularly when you have countries that really don't have the same privilege with finances and everything else that we would have, about how they manage their services. And what you often find with countries who have very little resource is that they're the most creative when it comes to reaching out to people. So the small organisations, the drug user led organisations are amazing. So that's one thing for Scotland. We don't have a strong network of people who use drugs. We have strong voices from people who have lived experience, who are now abstinent in recovery, but we don't have this sort of movement of people who still are experiencing the issues, that are able to really have a voice for change. And we try and do some of that through our organisation, but you know, there isn't a specific Scottish network of people who use drugs, for instance, whereas, you know, in Canada they have strong movements like that. In other countries they have strong voices of people who use drugs. So it fascinates me that we don't pay enough attention to the voices of people who are currently experiencing the issues, but we'll speak to people who used drugs 20 years ago. Things have completely changed since then, so we absolutely need to do more to encourage that voice to inform policy. What I would say about Switzerland is they're a country that we refer to a lot because they have been extremely progressive in their provision of services and drugs policy. So they used to, you know, probably be familiar that they used to have Needle Park, which basically like an open drug scene, and then they made this decision that they would provide mass provision of heroin assisted treatment and drug consumption rooms. So yeah, they are absolutely a global example to look to for, especially for the provision of heroin assisted treatment, and something that we've had a lot of input for to inform Scottish policy in that area. I'm not sure that really answered your question.
Absolutely. Thank you.
May I jump in? Because you said you'd been working with SDF for 9 years, you must have seen the organization develop. And I wanted to ask a bit more about your perspectives on, like for instance, does SDF have a relationship with the CND, with the Commission on Narcotic Drugs, or is it more of an in the field kind of, you know, strong relationships with police and hospitals? yeah, if you could talk a little bit more about the organization and your experiences with it for the past 9 years. Thanks.
Thanks. So SDF's been around for over 30 years now. I should really know the exact amount of years, but Dave Liddell, who's the CEO, he's been there since the start. So he's the one that's been involved in all these types of international groups, mostly on a European scale, I would say. So we're still linked in a lot of civil society groups on a European scale. Hopefully we'll be able to maintain those. Given that we're now out of Europe, but it looks like we will. So yeah, linked in more to the European civil society networks. But yeah, I mean, over the course of the 9 years even that I've been there, I think, you know, because my work specifically focused on drug death prevention, I've definitely seen a shift in, you know, what's happened through the organisation. And I guess it's a slightly difficult one because a huge proportion of our funding comes from Scottish Government, but at the same time, we absolutely need to be a challenging voice against Scottish Government policies. And, you know, so it's, although we would never not speak out, it is a fine balance for a lot of organisations. So I think we've been a sort of good critical friend to a lot of the things through Scottish Government, and it's been, you know, whilst we've not been members of the Drug Death Taskforce, I think that's been a good position for us to be in, actually, just as observer status, because it allows us to develop things in the background and to continue with the work that we are doing and not under the proviso of the Drug Death Taskforce. So the taskforce has been supportive in helping us push some of the work that we'd already been doing. But SDF as an organisation has got so many different pockets of work within it. So we've got an addiction worker training project that trains people with a history of drug use to get an SVQ to work in the field. And that's a really successful project. We've got other teams that work on sexual health and bloodborne viruses and, of course, HIV work. We've got our workforce development side of things. And I think that, for me, is probably the major development that's required over the next while. Certainly, having worked within the drugs field, we don't have a good framework or structure for people working in the field. So there's a definite need to provide people with that type of structure to get informed, get accurate evidence-based information. I mean, it's pretty shocking actually when you dig into the detail of that and how qualified actually people are to be working in some of the services, and the lack of training and knowledge that they get for working in this really important area. So again, I probably went a bit off your question, but I think over the next 5 years will be some of the most interesting times in Scotland for drugs policy that we've ever seen.
Thank you. Please go ahead, Patricia.
Kirsten, can I just ask you something about you mentioned the Misuse of Drugs Act and that people wouldn't have known anything about drug consumption rooms then. But in fact, there were drug consumption rooms run by some of the voluntary sector agencies in London in the 60s and 70s, but that history doesn't seem to have been drawn upon. And I wonder why that is, because there is a kind of precursor in history. And the other question I wanted to ask you was related to Scotland's impact on English drug policy. With HIV, we saw, you know, Scotland ahead of the game with harm reduction, and that had a huge influence on the later ACMD report. From what you're talking about now, it seems that Scotland is still trying to do things which are ahead of the game, and I wonder how much influence is that? Are you ahead of the game as far as English drug policy is concerned? And is what's going on in Scotland having any influence on England?
Thanks, Virginia. Yeah, and I appreciate that, and especially in the Netherlands, there was a lot of activity around drug consumption rooms in the really early days, and I guess they just wouldn't have been called that, and they wouldn't have been, you know, seen as that, and it would just have been a space where people would use drugs, and quite often referred to as shooting galleries and all sorts. So yeah, I appreciate that there would have been a lot of that in the very, very early days, but the Misuse of Drugs Act certainly doesn't take into account any of that. They often don't even take into account the expert advice that they get from the CMD, so a difficult one. So yes, I think that is still definitely outdated and needs looked at. In relation to your other question around, sorry, that's just gone out of my mind. Go and just give me a couple of reminders.
Scotland being ahead, although
yes,
it should
I
be
knew I was going.
more,
I knew I was going somewhere with that. Yeah, so I think things have been 10 times worse in England, and that in a lot of services, so I know people who work directly within drug services, a lot of services were actually banned from talking about harm reduction. The mere words were seen as something that shouldn't be used. So that was an incredibly difficult time. And obviously it's completely different the way that treatment services are structured in England as well. So most of ours in Scotland are NHS led, whereas most of the treatment services now in England are third sector led with prescribers based within them. So that's, we could probably do with some of that model as well in Scotland, a bit of both. But it's then, it's then meant that a lot of the services down south have had the monopoly on, how things are provided. And I think they have actually done a better job at getting more people into treatment over the last few years than we have. But in relation to UK government policies down there, I think are way more restrictive, particularly there certainly isn't as wide-scale provision of naloxone as there is in Scotland. So it's a bit more of a postcode lottery in England. And that's something that is changing and it is getting better. But they also had a recent funding announcement of 80 million towards drug deaths, which isn't really a drop in the ocean compared to what Scotland's now promised for the next 5 years. So there are frustrations definitely from services. I think in relation to drug consumption rooms down south, we're awaiting this Carol Black review that's coming out soon, which one of the things that was looked at through that review, led to believe by people that are more familiar with this issue than me, is that consumption rooms, decriminalisation and whatnot have, these are all the things that were being looked at through that review. Slightly easier down south to implement things because they have their police and crime commissions, so a lot more localised possibility for development compared to here. So if a police force, for instance, in England was willing to support drug consumption rooms, I think they would be able to develop something like that a lot more easily than we could in Scotland. So I think we will see some of that development. I've just been joined as a member onto the Drug Science Safer Injecting Facility Working Group, and that's what they're looking at across the UK about how to develop these services within current legislation. So yeah, interesting times, but major differences, I would say, although still high rates of drug deaths in England obviously as well.
Thanks very much.
Thanks.
Are there any final questions we have for Kirsten? If not, we are coming to the end of our time slot. So I do want to tie up some things, and then we'll have Ago close as our center lead. I think some of the major findings of all the wonderful papers we've had over the last 3 weeks are, first of all, how Scotland is in the global in a variety of ways. It's affected by global trends. It's also seen as a model, as Kirsten has shown us today, but it's also somehow distinct. And I wonder if that's something that everyone can kind of see in every single country, wherever you're from or wherever locale you consider home, this dynamic between being affected by, influencing, being a model, and being distinct. some impactful moments for me as the organizer from each of the papers. Ray's statement that you just had to act, people made decisions, not institutions. That was really a memorable moment for me. Hannah's statement that social workers were negotiating family dynamics, especially parent-child relationships, and communicating HIV care. Jim's statement that there is no evidence of anything other than medical use of opiates in early modern Scotland. That may be an archival thing. That was fascinating. Alex's statement that even with different health communication strategies between Scotland and England on anti-drug education campaigns, sometimes the outcomes were the same. And finally, Kirsten's statement today that language affects how people see themselves and the care that they receive. So those were the impactful moments from this seminar for me. We will have a web page up with the recordings of each seminar. We're working on that, as well as a paper we're preparing either for SHAD, the Social History of Alcohol and Drugs, or Polyphony. I'm still kind of working on that. But thank you so much for attending. Maybe Ago, you can close for us with the Beyond Global Aims.
Yes. Thank you, Reiko. For those of you who don't know me, I'm Agamoni Ganguly Mitra. I am a bioethicist and one of the co-leads with Steve Sturdy on the Beyond Global theme of our Center for Biomedicine, Self and Society. And I think this was such an excellent topic chosen to discuss the global and Scotland within the global, because this is truly a global issue and has such multiple levels and many, many dimensions. Political, regulatory, social, and what sort of stayed with me today, especially Kirsten, after your talk, the need for talking about the humanity behind all this, right? That there are stories, that there are humans, that there are relationships behind this story, and this is something that we often forget when we talk about sort of high level regulation and principles and all of that. So that was really important for me as well. I wanted to also thank all of the speakers of this series on behalf of the center. And this really has been an excellent series, and thank you also to the participants for your questions. It's been enriched and I've certainly learned a lot. Also look forward to catching up on those talks that I missed, unfortunately, as I was on leave. And also wanted to thank you, Reiko, for an excellent organization, for getting some excellent speakers. Thanks to you, we got to hear some experts in the field. And yes, thank you all. Have a good day.
Thanks very much.
Bye. Thanks for joining.